And it's my honor to also introduce Dr. Kush Desai, who is Vascular and Interventional Radiologist and Associate Professor of Radiology, Surgery, and Medicine at Northwestern University. Dr. Desai trained and did medical school at Northwestern University, as well as his diagnostic radiology residency and fellowship in VIR. And he has special interests in venous thromboembolism disease, DV thrombectomy, thrombolysis, reconstruction of chronic venous occlusion, IVC filter management and retrieval, as well as interventional PE management. And today we'll be hearing from him about VTE disease. Thank you.
Thank you. And it's always hard to follow Kumar. I'm also from the wonderful city of Chicago. He said the state. We're not quite a city state yet, although our mayor might make it that way here. We're going to be going from red to blue, modern DVT intervention. And I would argue that IR has really taken the leadership role in the developing field of venous intervention. And we're going to be talking about an IR-led pivotal randomized controlled trial that really informs how we take care of acute DVT patients today. So we know that DVT affects 900,000 patients. There's 900,000 cases of PE and DVT with 60 to 300,000 associated deaths. The usual risk factors of illness, surgery, and immobilization are all something that you're all aware of. And when most people talk about DVT outside of the vascular field, we're talking about the medical management, which is prevention of the extension of thrombus, preventing acute PE from occurring, limiting the development of late complications, and we'll talk about what that means, and then reducing the risk of recurrent thrombus. But despite really high quality anticoagulation that's much easier to manage than the legacy drugs, we still have a 5 to 15% per year risk of recurrent thrombosis in most groups, and PTS, as we're about to show, occurs at an alarmingly high rate. About 50% of patients at 2 years from the inciting event will go on to develop PTS. About half of those go on to develop severe PTS, and ulcers occur in 10% of patients. And unlike arterial disease, this affects a very wide cross-section of society. We see 18-year-olds, 20-year-olds, 30-year-olds with this disease. So the time horizon for this to impact their quality of life is very significant. The risk factors over one VT event portends an up to six-fold increase in risk in PTS. Older patients certainly suffer more, but we've certainly seen very young patients with it. Suboptimal anticoagulation is less and less a problem unless we have non-compliance, but the agents have been much better. And then those with persistent symptoms at 1 month from diagnosis. We also know that patients with iliofemoral DVT are much more likely to have PTS relative to FEMPOP DVT, and that's been borne out in randomized control trials that we'll show in just a few minutes. They're twice as likely to have recurrent VT and over 50% PTS rates. Speaking of QOL, we know that patients with bad PTS have QOL on par or worse than diabetics, chronic lung disease, and arthritis. And those with the severe PTS will have quality of life comparable to those with angina, cancer, or congestive heart failure. Pathophysiologically, thrombus deposits at valves that the valves then undergo an inflammatory process that damages the valves. They no longer close and coapt. And you also get wall damage. And once you have wall damage, obstruction, and valve damage, that results in ambulatory venous hypertension, so that when patients walk or are upright, they become very symptomatic. So the idea being that if you are able to frontline remove that thrombus, you might be able to bend the curve on PTS rates. And that's the genesis of the open vein hypothesis that really grew in prominence during the 2000s, and certainly was the hypothesis behind the ATTRACT trial. And I would argue that even though this was published in 2017, it very much is the center of conversation in 2024. As I pointed out before, this was led by an IR, Dr. Suresh Vedantam. He's a pioneer in this area and really somebody we should all look up to, because you have an IR-led vascular trial that ended up getting published in the biggest medical journal in the world, and with a number of sub-analyses that followed from it that really inform how we should take care of these patients. So this was an NIH-sponsored phase 3 multi-center randomized open-label assessor-blinded trial. Why is assessor blinding important? We're not going to be talking about trialsmanship here, but if we, as the operators, assess our patients in trials, we're much more likely to imbue our bias. We think we're doing the right thing. If you have blinded assessors, then you cut to the truth, and you're able to really see if you're helping patients or not, and potentially avoid unhelpful therapies. They enrolled almost 700 patients with proximal DVT. They had a combined primary endpoint combining FEMPOP segment and iliofemoral segment DVTs. And what they found was that there was no difference in PTS incidence or general slash venous quality of life between the treatment and control arms. But I highlighted the word incident specifically to point out that they define PTS as anybody that had a Villalta of 6 or more. Villalta is one of the PTS scales. We don't have time to talk about it, but a Villalta of 6 is not terribly symptomatic. Often patients with bad superficial venous disease will have Villalta, but certainly that's what we knew in 2006, and that's how we had to assign our assessments during the ATTRACT trial. They did notice a higher major bleeding rate in the pharmacomechanical arm, but none of them were life-threatening. The only one was a retroperitoneal bleed that required embolization. There was no intracranial hemorrhage. If we move on to the stratified analyses, in the iliofemoral cohort, they had 391 patients, and again, PTS occurrence showed no difference at 6 and 24 months. But when you looked at the more severely affected patients, those that had a baseline Villalta of 10 or greater or 15 or greater, they actually showed that the severity of PTS went down and there was improvement in venous-specific quality of life. Again, they showed no difference in bleeding or change in recurrent DVT rates. So the take home here was that those that had iliofemoral DVT, specifically involving the common femoral vein or above, had a benefit with reduction in moderate to severe symptoms at presentation. What about the FEMPOP patients, which really reflects and represents the majority of patients that come into the ER? And this was 300 of those patients. And across the board, they found really no difference in all PTS metrics. And there was no difference in venous-specific QOL. There were 3 major bleeds in the pharmacomechanical arm and none in the control arm. So really the take home from this is that most FEMPOP patients probably are not going to benefit from this therapy. Why is this important? If you try and imagine a world where every patient with popliteal or above DVT gets an intervention, I'm not sure that's a world we all want to live in. You're going to be filling up ICUs with patients. Our labs are going to be glutted with patients, and it probably just doesn't make sense. So again, ATTRACT showed us who we should treat and who we shouldn't treat. Moving on to another analysis of ATTRACT, this was 381 patients, and they looked to specifically identify baseline factors associated with stronger, higher quality outcomes at 24 months. And if you look at this curve, they actually showed that you can use a Villalta scale, which is a PTS metric, to actually talk about how sick your DVT patient is up front. And in a lot of vascular disease and arterial disease, we have a way of doing that with Rutherford classifications and other things that you can ask the arterial experts about. But we had no way of talking about it with DVT. You would just say his leg's really swollen or her leg's really swollen. You wouldn't have an objective way of talking about it. And what ATTRACT showed us in a bias-limited, randomized, assessor-blinded population is that the sicker they are with reflection of the Villalta scale at intake, the more likely, the better they're likely to do following intervention, provided that they're a good intervention candidate. So again, the take home here is that appropriate procedural candidates with a Villalta of 10 or greater actually showed benefit when they underwent endovascular therapy. So there's some perspectives from this. Should pharmacomechanical therapy be the first-line treatment, or really endovascular intervention be the first-line treatment for all proximal DVT? And really, no, it shouldn't. We probably knew this from ATTRACT, but now we have real confidence from a randomized control trial to say that that's the case. Those with iliofemoral DVT with at least moderate to severe symptoms at presentation, and those that are going to be compliant with their anticoagulation and follow-up are much more likely to do well. But the role is different. We've moved to less lytic, we've moved to single session treatment, and we've moved to mechanical only devices, and these have not been studied in rigorous trials yet. We'll go on to how I do it, and really, I like to select patients within the first 14 to 21 days. After that, I find that they've often organized quite a bit, and you're much less likely to get a durable intervention. So if that's the case, and they're coming into me at 30 days, I often will just start them on anticoagulation, bring them back, and treat them as a PTS patient with a recanalization downstream. And I can certainly answer questions about that later. So just to demonstrate a case, this was a 35-year-old male with new onset left lower extremity swelling and pain beginning 2 days prior to presentation. He had no prior history of DVT. He's a half pack per day smoker, had a lap chole 2 months prior, so he was considered a provoked DVT. He had 2+ pitting edema, and you can see on his ultrasound that he has complete occlusion of the left common femoral vein. So by definition, he is an iliofemoral DVT. We do the CT scan here, and actually it's important to do the CT scan in these cases, or at least some sort of imaging of the pelvis, because not only is it confined to the iliac vein, you can see that it's going all the way up into the vena cava to the level of the renal vein. So we're going to have to think about how we're going to manage that from our endovascular intervention. So what I typically do is I put these patients prone, and in this case, I am going to place a filter. For the vast majority of my DVT interventions, I don't, but I'm going to place a filter, and I'm actually going to plan on removing it immediately after my thrombectomy procedure. So I do this under general anesthesia. I place an EJ access, and then I put this patient in a prone view down. You can get to the EJ axis very easily when the patient is in a prone view. I do two-sided access for this patient for a very specific reason. Because you have cable involvement, and again, you see that there's femoral vein involvement here, but because you have cable involvement, not only am I going to be able to place a filter from a pop axis with a specific type of device that you see here, but I also use that second axis to perform IVUS. And the reason why I'm going to do IVUS is that I want to try and limit the amount of blood loss and try to make my thrombectomy of the cable segment way more efficient than if I'm just doing it blindly under floor, because of course you can't see the thrombus. So here you see IVUS guided thrombectomy, and I'm not sure that this video is going to work. Sometimes it does, sometimes it doesn't. But I basically turn the switch on and off as I work my way down the cava, performing thrombectomy, and you're able to do this in a single session. And it looks like it might be frozen here. I got the pinwheel. And so we're able to clear out clear out the femoral vein very quickly here. Common femoral vein, expected post-thrombotic change in the iliac vein. This is going to need a stent. We kind of know that going into it. You can see the vena cava is clear, all on table result with the IVUS guided thrombectomy. We place our stent, and then this is what I use that EJ axis for. You can see that this patient is still prone. I don't need to turn this patient over. I just remove the filter in the very same procedure. This is follow-up, and again, just to echo what the others have said, follow-up is absolutely critical. I have 10-year follow-up on some of my patients. Once you place a device or place a stent, you own that device, and that patient is yours to follow for as long as you're practicing, in my opinion, or at least as long as you're in that location. So to conclude, DVT is a significant burden on patients and the healthcare system. We know about the long-term sequelae of post-thrombotic syndrome. We've come a long way in the endovascular management of acute DVT because we have RCT data that was driven by interventional radiology to demonstrate the clear role for it in patients with moderate to severe symptoms and presenting with iliofemoral DVT. And we have a clear metric by which to assess these patients. But we need to define what the goal of our thrombectomy procedures are. It's not all of these patients. It's not the chronic patients. Those patients are PTS patients. They're not thrombectomy candidates. And I think there's been this push to try to do thrombectomy on these patients, and there isn't clear benefit. So I'm happy to answer any questions. I know that was a bit of a whirlwind tour.
Thank you so much, Dr. Desai. Excellent. Yeah, we do have time for questions if we have any in the chat.
Yeah, Dr. V just wrote, how do we nail the left iliac vein ostium?
Yeah, that's a good question. So what I typically do is I use IVUS to show me exactly where the compression is. And then just to echo what Kumar said, we are not only better with our wire catheter skills, we're better with our imaging than virtually all other image-guided practitioners. So what I typically do is I park the IVUS exactly where my compression is. Then I mag up, or actually first I measure the length of my stent because there are markers on the IVUS catheter. Then I mag up and I center exactly where on the IVUS marker is on the compression site. I lock the table and I do a fluorofade of exactly where the tip of the IVUS catheter is. Take the IVUS catheter out, and then you nail your confluence that way because you land on top of the ghosted IVUS image with a locked table.
Thank you. And Dr. V is also asking, how do you size it?
DVT, it's hard because you often get false dilation. So really don't ever need anything more than a 14 or 16 millimeter stent. I've placed one 18 millimeter iliac vein stent in my life, and it was in a 7-foot individual. So if you're using on-label nitinol venous stents, if it's an average size individual, 14 millimeters. If it's a larger male, particularly, I would usually do 16 millimeters. But it's hard to size them based off of IVUS in acute DVT.
Thank you. And are there certain patient populations considered at higher risk when you're considering going straight to intervention instead of primary pharmacological therapy?
Well, it's what ATTRACT shows us, right? So if you have involvement of the common femoral vein, if the patient has a robust activity level prior to the event, and they're going to be compliant with their anticoagulation, then that's going to be a good procedural candidate. On the flip side, you have somebody at the end of life, they're probably not going to derive benefit from PTS risk reduction, right? And if you have a patient that's bedbound or has poor quality of life from other comorbidities, a DVT intervention is probably adding risk instead of benefit. And so that's where selecting your patients is really important.
All right, and we have another question in the chat. How often do you stent past the inguinal ligament?
In acute DVT, not often, because if you're getting to them in the first 14 days, you usually should be able to clear out the common femoral vein. If you somehow miss the disease, or maybe the patient doesn't recall exactly when symptoms started, I would say that you need to often extend across the ligament to ensure that they have good inflow. And it's unlike arterial disease, you can stent across the inguinal ligament. In venous disease, and if you don't, you often have missed inflow, and you can have reocclusion.
Thank you. And I guess I just have a question. It's a recurring theme, like we heard at ICIT, that IVUS is really helpful in procedures, like for being precise and also improving outcomes. How do you think can encourage more people to use IVUS?
I think you need to answer what you're using it for, right? You use it to answer a question. And I'll tell you, when I first started doing these interventions, I did not use IVUS because I was just being told, if you're not using IVUS, you're not performing the gold standard of imaging. And there's never any answer to my satisfaction as to why you needed to use IVUS. And so the more and more I did cases, and then I finally gave it a shot, I understood what questions it answered for me. So for me specifically in acute DVT, if I'm landing my stent, where I need to land my stent, how long my stent needs to be, and to ensure that my inflow is good, right? But those nuances are often not conveyed on podiums unless somebody's really talking about IVUS. They're just saying, oh, if you're not using IVUS, you're not doing the right thing. So it really is, it's changed the way I do DVT intervention. I personally wouldn't do any venous intervention without IVUS. But you need to have, just like any test you order, you need to have a question, you do the test, that test answers the question.
Perfect. Thank you so much, Dr. Desai, and thank you to all our vascular intervention speakers.